Hello, I'm Simon Bott. I'm a consultant urologist working at Frimley Park Hospital, covering patients from Surrey, Sussex, Hampshire, and Berkshire. I have a specialist interest in prostate cancer. I did research at the Institute of Urology at University College Hospital for 3 years in the molecular genetics of prostate cancer. I then trained in a number of different techniques to diagnose and treat prostate cancer, and I've been a pioneer in novel ways to diagnose prostate cancer. When I first started training, the way we used to diagnose prostate cancer was using ultrasound, and some hospitals still use this to this day. Ultrasound is very good at enabling us to see the prostate, but unfortunately it doesn't show up prostate cancer. But we used ultrasound scan to direct where we did prostate biopsies. So if we take this slice through the prostate on an ultrasound scan shown on the screen, you can see that if you had a cancer in a spot perhaps at the front of the prostate and my biopsy came in through the back of the prostate, I may miss the cancer. I may then tell the patient that they don't have cancer when it really was the fact that I missed the cancer in the first place rather than they didn't have the cancer. Otherwise, I might just clip the edge of a large cancer, think I've only got a small cancer and tell the patient, don't worry, this is only a small cancer and doesn't matter, when really it's because I've inadequately sampled that lesion. Finally, a lot of men have very small cancers that never matter, that will never affect them during their lifetime. I don't need to diagnose these, but inadvertently I may hit this cancer and then the patient has a diagnosis of prostate cancer for the rest of their life when they probably never needed to know anything about it. This is why we came up with the idea of a template prostate biopsy, which I was the first to describe in the world in 2004. This enabled us to do an ultrasound scan, but at the same time, we placed a grid over the prostate, and this enabled us to sample the whole prostate systematically. We could take biopsies every 5 millimeters of the prostate to ensure we covered it completely. The trouble with this technique is patients ended up having a lot of biopsies taken. Anything between 70 and 100 prostate biopsies were taken. So we needed to do this under general anesthetic. But it was an improvement on the previous technique where we often missed prostate cancer. I was then involved with the PROMISE trial, which was a study across the United Kingdom where we looked at the role of MRI in diagnosing prostate cancer. Previously, MRI scans had just looked at the anatomy of the prostate. But abnormal areas of anatomy in the prostate don't necessarily correspond to prostate cancer. We also need to look at various other factors in the prostate to see whether there may be cancer there. So we look at the amount of water in various parts of the prostate because prostate cancer has less water in it. And we look at the blood flow because blood flow is increased in areas of the prostate that have cancer in it. And if you combine those three scans, it's called a multiparametric MRI scan, looking at the anatomy, the amount of water, and the blood flow, we can very accurately predict whether or not there is any cancer in the prostate, and indeed avoid unnecessary biopsies in people where there is no cancer. So the left-hand image shows you a picture of an MRI scan. It's a tunnel that you go into, but your head remains out of the scan, and the scan takes on average 35 to 40 minutes. On the right, in the top left picture, this shows you the anatomy of the prostate, that same slice through the prostate. But you can see in the top right-hand part of the scan, there's a darker area pointed out by the arrow. So this is an anatomical area of abnormality that may be prostate cancer. But 50% of these dark areas are not cancer. So we have to look at the amount of water. So if you look at the image below, you can see there's a white area corresponding to that black area in the image above. And this white area indicates that there is less water here, and that is therefore very likely to be a prostate cancer. It's about 90 to 95% accurate. The top right picture shows the amount of blood supply going to the area of the prostate. And again, you can see here, there's more white here, indicating there's more blood flow to this area, reinforcing the fact this is very likely to be a prostate cancer. The trouble with MRI scans is that although they can very accurately see the prostate and see any abnormal areas within the prostate, it's very difficult trying to access the prostate to do a biopsy to confirm the diagnosis with a patient in a noisy tunnel. We can still use ultrasound to see the prostate, but as I mentioned before, ultrasound doesn't see abnormal areas within the prostate. So what we need to do is use the MRI to direct how we do the biopsies using ultrasound. So this is a very expensive but very useful piece of kit that I use. I was the first person in the country to use this, and now there are only 3 or 4 in the country, in the United Kingdom, of these pieces of kit. But these enable me to see the MRI scan as I do the ultrasound and do the biopsy. So first of all, what we do is we take the MRI scan of the prostate, and I draw around the prostate like that. And I draw around that through the prostate from head to toe. I then mark on the scan where I think the abnormal area is, outlined here, the prostate in blue and the cancer in red, or what I think is cancer. The clever software on this piece of kit then makes a 3D model of the prostate based on the MRI scan, shown as the blue net here, with the abnormal area shown in red. I then do an ultrasound scan of the prostate, and this blue net and the red area is overlaid onto the ultrasound scan, as you can see in the image in the bottom right. I can then stick my needles through the abnormal areas and ensure that I've hit the area that I'm interested in particularly, and also sample the rest of the prostate as required. This enables me to have a record afterwards of exactly where I biopsied. So if I need to come back at another date, I can check where I've been. This is a much more accurate way to diagnose prostate cancer. It limits the number of biopsy cores I have to take, which means I can do it under local anesthetic. And it also means that patients suffer less because I'm taking fewer biopsy cores. We've not had a single case of sepsis using this technique, a nasty infection that we used to see in 3 to 5% of patients undergoing the standard biopsy. What I'm finding is I'm taking fewer biopsy cores, which is much more comfortable for the patient, and it also means I can do it under local anesthetic. But the biopsy cores I am taking are a much more accurate representation of what the tumor is actually like, because I can be absolutely sure I've gone bang through the middle of that tumor, and therefore an accurate assessment can be given by the pathologist of that cancer. It's really important in the diagnosis of prostate cancer that we get the diagnosis absolutely right, because some men we can afford to just watch and observe, and other men need treatment, and they need treatment fast. In order to do this, we need to have the best quality MRI scanner. This should be a 3 Tesla scanner and a multi-parametric scan, and we need the best way to biopsy the prostate, which is a fusion-targeted template prostate biopsy. This gives us the best information, which gives us the best outcome for patients.